Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Welcome to Central Line. I'm Dr. Keya Locke, your host. Today I get to talk with Doctors Barbara Rogers and Shobana Rajan, guest editors of the August Monitor, about perioperative medication management. It's an important topic, and I really can't wait to hear what you both have to say. So welcome to the show.
Thank you. Thank you so much.
No problem. As we often do, I love to start with introductions. So if you both could introduce yourselves and tell us a little bit about your path, your role, and your interest in perioperative medication management.
This is Barbara Rogers. I'm a professor of anesthesiology at the Ohio State University Hospital's Wexner Medical Center. I specialize in neuroanesthesia and preoperative medicine. I've been doing this for quite a long time now, and I'm very interested in preoperative medicine because it really is one of the most important things we do is before we take care of a patient, take them to the operating room, is to have an idea of what their medications, what their surgery past has been, and what their medical history is currently.
Hi, I'm Dr. Shobana Rajan. I work as an anesthesiologist and am the program director for the Neuroanesthesiology Fellowship at the Cleveland Clinic in Ohio. And my special and strong interest is in the area of perioperative neurosciences and patient optimization. So at the Cleveland Clinic, I've had the opportunity to work with complex surgical populations, and this has really deepened my appreciation for managing the nuances in preoperative medications. I also serve as the chair of the International Council for Perioperative Neuroscience Training, and because of this, I get to work and collaborate with neuroanesthesiology fellowship programs around the world. And therefore, we do a lot of collaborative work in global education and standards in preoperative medications as well in order to standardize training and education. So I feel that management of the preoperative medications has a very important role in the total perioperative care of the patient, and therefore I am very much focused and interested in this area.
Thank you so much. And you both have touched on the importance of this topic. Specifically to Dr. Rogers, I would say we make decisions about medication management every day, and so it may seem routine. Do you think that it is? Or is it getting increasingly risky or at the very least complex?
I believe that because of our patient profiles, patients are getting sicker, and we are also pushing some of these sicker patients out into ambulatory settings, that having medication management reviewed and making sure it's correct is increasingly more important. Joint Commission has added medication reconciliation to one of their goals, which I think is appropriate in their priorities. There is multiple ways in any large system, which hospitals are large systems, errors occur. And having this addressed and looked at beforehand, I think is really important. So Joint Commission wants there to be a reconciliation basically every time there's a transition of care for patients, is my understanding. So if you come in through the ER, there's a transition. Once you go to the floor, there's a transition. Between departments, there's transitions. And when you walk into a clinic, there's a transition. So having the right medications, knowing what those medications are, double checking the medications, I think it's very, very important. There's just so many places where you can have errors. And even if you believe you think you know what the medications are, there could still be errors because there's errors of omissions. Patients forgot that they're on this. Even if you have the right medication, you could have the wrong doses, the wrong timing. Maybe the patient thinks they're taking something, they stop taking it, or they don't tell you they're taking something because they kind of forgot. So I think it's extremely important before we have patients go to surgery that we actually know what the medications that they are taking and how that's going to interact with the medications we give them and how it's going to interact with anything that happens after surgery.
Right. Thank you so much for that. And digging a little deeper, it would be good for us to try and look at sort of the debate over more familiar medication like angiotensin converting enzyme inhibitors and angiotensin 2 receptor blockers or ARBs and whether or not they should be held on the day of surgery. What were your thoughts about the current thinking? And are we even asking the right questions, or should we be sort of looking at this through a different lens?
Yeah, so interestingly enough, there's been a consensus statement by the cardiologist for patients having non-cardiac surgery. That's not last year. Was the 2024 AHA-ACCA has guidelines for perioperative cardiovascular management in non-cardiac surgery patients. And they have an actual little box that kind of goes over this. And I think the most interesting thing is that the debate continues because basically their recommendations for perioperative renin-angiotensin aldosterone system inhibitors is that in select patients, these chronic drugs for hypertension have some sort of elevated cardiac risk that you would want to hold it 24 hours before surgery, which is a very common practice, I think, in most surgeries that are going to have large shifts in blood pressure, or you're really, really worried about refractory hypotension affecting the patient during surgery, which is what some of the studies have shown, that if you continue it, that they might have this refractory hypertension that's very hard to treat and just exacerbates conditions if you lose a lot of blood or lose a lot of fluid, or it's just critical that they have maps that are at a certain level. So that's kind of, they talk about that. But on the other hand, they say, on the other hand, if patients have this certain kinds of heart failure, that they say that's maybe reasonable to continue it. So I think that's an interesting, because basically it's kind of saying, yes, you could continue, or no, don't continue it. So I think that there's still debate about the right way to treat these medications. So again, I think it's very important to look at the patient, look at their surgery, individualize what you do with these medications, and kind of understand why you're stopping it and why you would continue it. There's also some studies recently. One was called the SPACE trial, where I believe they stopped the medications for more than 24 hours. The most common thing that you will see is actually holding for 24 hours. And they found that maybe it didn't matter. Maybe they didn't have any long-term morbidity or mortality. But I think the question again is, maybe if not the long-term problems, maybe it's the problems the day of surgery. So I think that we still need more research and more consideration around that class of medication.
Yeah, it sounds like, once again, there's no right or wrong answer strictly. But I appreciate what you're saying about really individualizing and looking at people the day before or whenever, but just on an individual basis. In the same vein, what were your thoughts about GLP-1 receptor agonists? And can you tell us a little bit about the risk-benefit approach for a preoperative GLP-1 RA management?
Right. So there's some thoughts about what we should be doing with these glucagon-like peptide receptor agonists, or GLP-1 medications. And when these came out, it became very popular the last several years. One of the concerns is that it slows gastric emptying, which is partly how it works. What makes people feel full longer and they don't want to eat. And that this may create aspiration risk for some patients. So there's been several societies that publish guiding documents saying that maybe these should be held, but how long do you hold them? And there's been various ideas about this. Maybe one day isn't enough, because then there started being case reports of patients having, vomiting or possible aspiration. So this has kind of been a hot topic, I believe, too. Like, what is the risk of holding this? How long you should hold it? And what's the risk of continuing in different populations of patients? Evidently, most of the aspirations that occurred were in these case studies were patients that were having moderate anesthesia care, where they weren't actually intubated, but they were sedated. And so there was some thought that maybe that was part of the problem, that maybe, if you don't have a protected airway, they're more likely to aspirate. But with that in mind, many of the scientists had got together and tried to review what literature there was out there, and came to some realization that maybe holding them for way longer than one day would be reasonable. But then, of course, there's risks and benefits of stopping these also. So one of the concerns was that if you have a patient that's a diabetic patient, because you might be on this for weight loss or you might be on for diabetes. And if you are on it for diabetes and you're holding it for maybe a week or 2 weeks, then their glucose management is going to be problematic. On the other hand, if you have someone who's taking for weight loss, all of a sudden they may have a hard time not eating because of the way the medication works. It makes them kind of feel ravenous right before surgery. So again, I think it's kind of an individual approach as far as if they're on it for weight loss or if they're on it for diabetes. So I guess there's been some studies that say if you have somebody that has a fasting time that's prolonged, like actually for 24 hours or so, they're on a clear liquid diet, maybe perhaps that would be safer than just having maybe an 8-hour hold on clear liquids. Again, it's still kind of debated on what's the best approach. There's also been some talk that maybe we should be using gastric ultrasound to see if the patient's stomach's full at the time of surgery. And if they're having a full stomach, maybe you should be canceling elective surgeries. But I believe that it's still kind of debated, but it may be the best approach is to hold it longer, having 24 hours of clear liquids, and then maybe 8 hours of low carbohydrate drinks before any surgery requiring anesthesia.
Thank you so much. Those are really important points that you hit on. And as you mentioned, the debate really is ongoing. As you alluded to, some of the diabetes medications are also a hot topic. Do you have guidance to share on that?
Yeah, so there's been some of the standard diabetes medication. Some of those have not really changed what we do with them, but there are some newer ones. And these would be things such as the dipeptyl peptidases or DPP4 inhibitors. And there's some also bisolidinines that enhance insulin sensitivity primarily in adipose tissue and in hepatic tissue. They increase the glucose uptake and reduce hepatic glucose production. And some of these you're going to need all the day of surgery. And then if we go back to some of these really new medications, such as sodium glucose cotransporters or SGLT2 inhibitors, these actually, some of them need to be held for like 3 days before surgery, and one of them is actually a 4-day hold. So that is unusual for diabetes medicines that we would be holding them that long. So I would say that if you see these medications, really be cautious that you're holding them long enough. One of the issues that's brought up is that these SGLT2 inhibitors lower blood sugar by reducing glucose reabsorption into the proximal tubes of the kidney, and you can be excreting the glucose in your urine, and that you might get diabetic ketoacidosis during this time period, and that's why they recommend holding it for longer.
Thank you so much, Dr. Rogers. Switching veins a little bit, Dr. Rajan, my next question is for you. When it comes to managing chronic pain, there's a question over whether perioperative tapering should be considered and the challenge opioids present for intraoperative dosing. Can you talk to us a little about this?
Sure. When we care for patients with chronic pain, this question often comes up. Should we be tapering opioids prior to surgery? But then the answer to this question is not so easy, because on the one hand, there's a concern that patients on long-term opioids have tolerance to pain and their pain levels are going to be like sky high. So figuring out how much is enough for them in the perioperative period without tipping them into postoperative respiratory depression is pretty much like walking a tightrope. On the other hand, tapering the opioids prior to surgery, when the patients are already having so much anxiety, when surgery is on the horizon, that seems to be a little harsh as well. So it's always a dilemma as to what to do. Many patients are on drugs such as buprenorphine, and buprenorphine is a partial neoagonist. And so previous recommendations used to be hold the buprenorphine 72 hours prior to surgery, because the assumption was that it binds tightly to the opioid receptors and therefore it can block any other new agonists or other opioids that you're going to use for acute pain in the intraoperative period, making pain control relatively tough. But there have been many reasons to continue buprenorphine perioperatively as well, because many studies recently have shown that there is much better pain control when you don't taper the buprenorphine and stop it, but actually continue it throughout the perioperative period. And therefore, the thinking has changed a little bit with respect to that medication. And when you continue buprenorphine in the perioperative period, the risk of withdrawal and relapse is also minimized and overall better outcomes for the patient. Take another drug such as methadone, for example. Now, this is a full mu agonist drug, unlike buprenorphine, which is a partial agonist. And this has a long half-life and it produces very stable opioid levels for many hours. And therefore, it's being used because it prevents withdrawal. But it can also complicate pain management if a patient is on methadone preoperatively. Because although the actual analgesic effects last about 6 hours, patients need not only their usual methadone dose, but they also need additional opioids titrated very carefully over the pre-existing methadone dosage that they're already taking. And therefore, this is like stacking opioids, and this can increase risk of respiratory depression and maybe other cardiac complications as well. Therefore, monitoring is critical when a patient is on medications such as methadone. Therefore, whenever one has a patient who's on a chronic pain medication, be it buprenorphine, methadone, or naltrexone, one needs to have a very thoughtful and an individualized approach, something that also blends multimodal analgesia using drugs like ketamine and dexmedetomidine. One should optimize regional techniques and, importantly, close collaboration with the patient's addiction team and the pain management team would be prudent. And therefore, these patients probably require a lot of planning, more time, and more vigilance, perhaps. But with the right strategy, I think one can keep them comfortable and safe.
Dr. Rajan, my next question is for you. Do substance use disorders pose challenges in the perioperative space, and what sorts of things should we know about that?
That's a great question. And without a doubt, I think it does pose challenges to us in the perioperative period. And I want to particularly focus on one substance, which is cannabis use, because it has been recently legalized. And we've noticed that many patients, especially the regular users of cannabis, need higher doses of anesthesia as well as more medications for pain management. And this effect does not seem to be subtle. These patients often have increased pain tolerance and even altered pain perception. And so we are now starting to ask the question, would pausing cannabis for a few days before surgery help reduce those needs? Obviously, it's a question we don't have fully an answer yet, but one that we could actively explore in the future. The ASA has also acknowledged this growing issue and currently recommends delaying elective surgery for at least 2 hours after acute cannabis use. But still, we don't have a formal guidance on how long to stop it ahead of surgery in the chronic users. But the key takeaway is we need to ask, document, and adjust accordingly. And this is not just for cannabis, but I think for other substances as well.
Thank you so much, Dr. Rajan. My next question, I believe there's some new thinking around anticoagulants as oral anticoagulants grow in popularity. What should our listeners know about balancing thrombotic risks with surgical bleeding considerations?
It's true that the direct-acting oral anticoagulants have made life much easier for our patients as well as the physicians in some ways. In the past, warfarin was used, and there was a lot of lab monitoring that was required to measure the INR frequently and things like that. But ever since the advent of these newer medications, there is no need for routine lab monitoring, and they have fewer food and drug interactions as well. However, when they come into the perioperative period, they do add another layer of complexity. Because one challenge is their variable half-lives, which depend upon the different drugs. And it also depends upon the patient's age as well as their renal function. So one needs to look into all these things to make the correct decision. And while we don't have to track INRs like we do with warfarin, if a patient comes in as an emergency and there's really no quick lab test which tells us where the anticoagulant effect stands. Sometimes we do not know when the patient took their last dose of anticoagulant, and therefore that leaves us confused as to whether the anticoagulant level is high or not. And reversal agents do exist, such as andexanate alpha and other drugs such as idarucimab for dabigatran. But again, they are expensive and may not be readily available, especially in smaller hospitals. So many times we're relying on clinical judgment, especially in the elderly patients and those with impaired kidney function, where the drug may actually stick for longer than we expect. So while these agents have simplified anticoagulation on the surface, they've made perioperative planning more nuanced. And it really comes to individualized assessment. What's the patient's clotting risk? Did they have a recent blood clot? Or did they have a recent coronary stent? Or what's the bleeding risk of the surgery? Is it a neurosurgery or is it an inguinal hernia where the bleeding risk is much less? And what resources do we actually have available if something goes wrong? So it is essential, again, to have a very structured approach to patient care for successful management.
Dr. Rajan, thank you so much. And Dr. Rogers, my next question is for you. Anesthesiologists are excellent perioperative physicians, and our role as pre-op physicians continues to increase in importance. Can you talk to us a bit about why we are uniquely situated for these roles and why it continues to be important that we embrace this sort of broader involvement in perioperative areas to the field of anesthesia?
I think that anesthesiologists are uniquely situated for being perioperative and preoperative physicians because of our role in seeing the patients before surgery as just our normal way that we do business, basically. We also see all the physiologic changes that occur in the operating room. We take care of patients through the preoperative, intraop, and post-op period. Plus, we're branching out into other areas. There's many physicians that are actually critical care physicians. We have new enhanced recovery after surgery protocols, which are many of them driven and initiated by anesthesiologists. These are protocols that are standardizing fluid management, opiate-sparing analgesia, early mobilization to short hospital stays. We collect data on these, monitoring and have continuous improvement projects surrounding this enhanced recovery. There's also many anesthesia-run preoperative assessment clinics where we actually are starting prehab programs designed to introduce some exercise, nutritional, physiological regimes to help boost patients' immune systems and increase their muscle strength before surgery so they do better after surgery. And many of these clinics are multidisciplinary. They collaborate with cardiology, pulmonology, nutrition to identify and mitigate these risks before surgery. We also have many anesthesiologists that are doing expanded research and innovation to step into this perioperative medicine area to help our patients. So I believe we're really well suited because of our background, our knowledge in this area, and then our innovation to increase the awareness of things that need to be done before surgery so our patients just do well.
Thank you so much. And before I let you both go, and starting with you, perhaps, Dr. Rogers, can you tell our listeners something that stood out to you about the issue, whether it was surprising or just the takeaway that you want our readers to be sure to pick up on?
I think the takeaway is that we know there are so many evolving medications out there. Many of us are familiar with the medications because we have had to learn about them because our patients are taking them, but not everybody is aware of all these new diabetes medicines or new thoughts on some of the other medications concerning chronic pain. So I believe it's a great issue to be a refresher course, number one, and number two, just to hear about the new ideas around medication management. And also, I think it's just important in general, as anesthesiologists that are taking care of these patients, to really have a systems approach in your hospital, your clinic, on how to manage and mitigate risks for patients on these, maybe not exactly high-risk medications, but all medications have risks. So to have a systems approach that decreases errors and have multiple systems in place to catch errors, which I think is basically what the Joint Commission is supporting us to do in general, is really important.
Thank you, Dr. Rogers. And Dr. Rajan, if you had something you wanted to say as well, maybe a takeaway that you would hope our readers would be picking up on.
So I completely agree with Dr. Rogers' takeaways. And I would just like to add that preoperative medication management isn't just a checklist. It's a clinical decision point that can affect the entire perioperative course. And I feel like we should be training the next generation of anesthesiologists, especially through initiatives like an edition in the ASA Monitor, where we really have this opportunity to elevate this topic.
Thank you so much.
Thank you so much for having us today.
Well, this was a great conversation. I really enjoyed hearing from you both. Thanks to you, and thanks to our listeners for joining us. You can learn more about this topic at asamonitor.org. Come back soon for more Central Line.
Hi, this is Dr. Jonathan Cohn with the ASA Patient Safety Editorial Board. The practice of anesthesia is occasionally marked by unexpected events, and the startle response that occurs can result in the delay of appropriate action or the initiation of inappropriate action. Hyperarousal can lead to tunnel vision, tunnel hearing, loss of accurate time perception, and regression in non-professional behavior such as yelling and panicking. This behavior can hinder the deliberative, creative, and collaborative approach required to successfully navigate the unexpected situation. There are several things that anesthesiologists can do to improve their ability to deal with the unexpected. Prior to the event, adequate self-care and mental rehearsal of contingency plans can help with preparation. During the event, it's important to summon help early and utilize cognitive aids to remember key management steps. Anesthesiologists can help mitigate the sympathetic response with tactical or box breathing techniques. Finally, after the event, ensuring adequate time for recovery and having support available is essential to being ready for the next event.
For more patient safety content, visit asahq.org/patient safety. Do your part to advance the specialty by participating in a quality registry through Anesthesia Quality Institute. Support patient safety, compliance, and business objectives at aqihq.org/registries. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.